Hello, everyone, and thank you for joining today's professional webinar, Fabry Disease and Women, the Role of Nephrologists in Diagnosis and Management. As a reminder, today's event is being recorded live. My name is Mike Spigler, and I am the Vice President of Patient Support and Education for the American Kidney Fund, and I'm so excited that you're joining us for today's presentation. I'd like to begin by thanking our corporate sponsor and educational partner, Sanofi. We are very grateful for the continuous support over the years, and we truly appreciate the partnership. Next slide. I'd like to start by introducing our featured speaker for today's webinar, Dr. Eric Wallace. Dr. Wallace is a native of Alabama. He serves as the Director of Telemedicine at UAB, the Director of the UAB Home Dialysis Program, and Co-Director of the UAB Fabry Disease Clinic. Since becoming faculty, his research has been focused on eliminating geographic and socioeconomic barriers which prevent patients from accessing specialized care. Primarily, he has focused on telemedicine and the provision of care in home dialysis and rare diseases such as Fabry disease. Currently, the UAB e-medicine program under his leadership now is able to deliver direct-to-patient ambulatory scheduled and inpatient care across the state. Inpatient telehealth programs include telestroke, tele-ICU, telenephrology, and telegeneral neurology. Dr. Wallace is passionate about home dialysis, and in 2020 was named as counselor to the International Society of Peritoneal Dialysis. Dr. Wallace, thank you for being here with us today. We're very excited to hear your presentation. Next slide. I'd also like to extend a heartfelt thank you to our other amazing educational partner for this activity, Women in Nephrology. We are so happy to be aligned with such a great organization such as WIN to highlight Fabry disease with a focus on women. Before we get started, a few quick housekeeping items. This webinar, as I mentioned, is being recorded. And if you're watching live, we do encourage you to join the conversation. Let us know you're here in the comments section and type in any questions you have using the Q&A feature on Zoom. We'll try to answer as many as we can with Dr. Wallace as we go forward. And at the end of the webinar, we will include a link to a brief satisfaction survey in the chat. You can also click continue after the webinar to get to the survey. We kindly ask that you take a few minutes to complete it. Your honest feedback will help us continue to make our programs the best they can be. And finally, if you're a healthcare professional and believe that your accrediting body may offer you credits for attending this webinar, simply email us at professionaleducation@kidneyfund.org. While this webinar is not accredited, we'll be happy to send you a certificate of attendance after today's session. And again, please note that this webinar is being recorded, and the recording will be available on our website and YouTube channel later this week. Now, without further ado, I will hand it over to Dr. Wallace. Dr. Wallace, you can take it away.
Thank you. I really appreciate it. So these are my conflict of interest disclosures. So I work with all companies that are currently doing research with Fabry disease and Natera, which is a gene panel company. So I want to make sure that that is clear. I'm being compensated for this talk, but definitely something I'm very, very passionate about is Fabry disease as I run the Fabry clinic at the University of Alabama at Birmingham, and as have had the opportunity of taking care of more than 100 Fabry patients and seeing their families. And I always tell people that you actually learn so much more from actually experiencing what patients with Fabry disease experience taking care of them than can ever be found in a textbook. So what I'd like to do is kind of impart some of my experiential knowledge with the people viewing the webinar. So the learning objectives of this is to discuss Fabry disease and specifically focus on women. Because women, for the longest time, have many, many stories of females who were told they were carriers. And lo and behold, they were not carriers and presented years later with kidney disease, cardiomyopathy, et cetera. And so, number one, to focus on females and make sure that everybody understands they are not carriers, they actually have disease. Number two, address baseline evaluation and monitoring in females. So, so that people understand that there's a reason to diagnose this. This is not just kidney disease. This is kidney, heart, brain, GI, et cetera, that really impacts quality of life if we miss it. And then finally, address the need for increased genetic testing in kidney disease in general. You'll never make diagnoses of rare genetic kidney disease if you don't test. We have a lot of options available that we historically have not had that has really expanded over the last 2 to 3 years. And we need to send the test. We cannot abdicate all responsibility. We as nephrologists cannot abdicate responsibility for genetic testing to geneticists. because it's integral to things that we need to diagnose and take control of. So the pathophysiology of Fabry disease is, Fabry disease stems from a deficiency in alpha-galactosidase alpha. And I always tell my patients that alpha-galactosidase is kind of like the trash man. And the lysosome is the trash can in your house. So if trash builds up in your house and you don't have a trash man to take it out, then all of a sudden the house doesn't work that well. And that's exactly what happens in Fabry disease, which is that you do not have the trash man. So you continue to produce trash, which is globotriacylceramide. Globotriacylceramide, it's either, depending on the manuscript, it's either GL3 or GB3. So those are the same thing, but that builds up in cells, specifically in the lysosome of the cell. And as it builds up, the cell stops functioning that well. And it turns out or GL3 builds up in all of the organs of the body. It is the sum total of the cells and their function that actually creates organ function. So if you have enough cells affected, then you get organ dysfunction and you get disease. And so these are just some kidney biopsies. And what you can see is that what's pointed out there is the GB3 in the lysosomes, specifically in the capillary endothelium is where we find them, but you find them also in really all cells of the body, including podocytes, mesangial cells, GI tract, neurons, et cetera. So these build up. This is important for us to focus. Yes, it is a kidney disease, but it affects everything. All right, so Fabry disease is X-linked. And so one of the first things that all my patients ask me, it's very heartwarming. So as a dad, I really link to this, because the first thing they ask me is not about themselves, it's what about my kids. So just be prepared as a nephrologist, you're gonna have to be able to answer what about my kids as your first question. And so as an X-linked disease, if you are a dad with a daughter, then that daughter is a daughter because you passed her the X chromosome. You only have one. So you passed her the X chromosome. So 100% of daughters of affected males will have the disease, period. Now, if you are a son of an affected male, 0%, because you are a son because the affected male actually passed you the Y chromosome, which does not house the gene. On the flip side, if you're a female who is affected, you have 2 X's, and each child, either a son or a daughter, has a 50-50 shot of inheriting the gene. So that is how this is passed on. So you can at least give your patients peace of mind, or at least statistics when they ask you about this. So females who carry the mutation are heterozygotes by definition, meaning that they have 2 X chromosomes, one is affected. But carriers, so when we use the word carrier, that implies that they carry the mutation yet have no phenotypic difference. They have no signs or symptoms of the disease, and anything could be farther from the truth. And what I'll demonstrate is that up to 70% of heterozygous females actually will have signs and symptoms of Fabry disease, and many will be just as severe as males. And we'll talk about the data behind that. So what are the symptoms? And most symptoms are actually categorized by affected males, because historically that's the only people we diagnosed because they were severe and classic. And because of that, we kept on trying to diagnose them, whereas females haven't historically had that luxury of us trying to diagnose their symptoms, because by and large, they were slightly more mild than males, right? So if you look at this graph, acroparesthesia is the number one thing that people present with is pain. And usually in males, it will present at the age of 5 to 10, where imagine, I have a 10-year-old now, and imagine, your son or daughter saying, my hands and feet burn. And then invariably what will happen is that these kids will go on, they'll go to their doctors, pediatricians, their neurologists, et cetera, and nobody will understand the disease process. They'll send a lot of lab tests, but nothing will come back positive. And invariably what will end up happening is that the child will be labeled as a pain seeker, attention seeker, somatoform disorder, you name it, they'll get labeled at anything but the actual disease state. So then what ends up happening, probably around the age of, for these classic males, they'll start getting a little bit of proteinuria in their urine. And then their creatinine will start to rise, and hopefully the nephrologist will recognize that and say, look, I have an unexplained disease with proteinuria. What do? We biopsy. So about 5 or 10 years ago, the average age of diagnosis for these patients was about 27 to 35. Now imagine you've had a disease that people have told you were crazy for, since the age of 5, and all of a sudden somebody gives you a name to that disease. And that's what we have the ability to do when we diagnose this. So ultimately what ends up happening is that patients will end up with a much higher risk of stroke than the general population. They will get cardiomyopathy, malignant ventricular arrhythmias, bradycardias, et cetera. And without treatment, the mortality of this, and when I say without treatment, before dialysis existed, the mortality was around the age of 40 because you had 40-year-old men needing dialysis, but such a thing didn't exist. And obviously that was alarming to people. And we were finally able to diagnose the disease. Luckily, there are things that we can do to try and prevent things like that, including Fabry-specific and adjunctive therapy. So now females, if you look at the same graph, right, ultimately females will follow this same pattern, except on average, they'll be about 10 to 20 years behind this. So, it's the same symptoms, same progression. It just happens a little bit later. That is not a carrier state. They do have a disease and can be significant. So let's talk about females not being carriers. So on average, females in general progress to ESRD 15 to 20 years later than male. Just like I said, it's just a little bit later. But it turns out in one study of registry data, of the females, there were a group of females that progressed to end-stage renal disease. Now, by and large, females, only about 2 to 4% of them will progress to end-stage renal disease. But the interesting thing about this study, this registry data, is that of the females that progressed to end-stage renal disease, the median age was that of males, which clued the researchers in to say, hey, look, there is a group of females that can be every bit as severe as males. So we have to figure out who's who, right? So there's females that are every bit as severe as males. There are females that are in between, a little bit, so moderate disease. And then there's some females that really don't have many clinical manifestations at all. And we have to figure out, how do we determine which is which, right? So severe clinical manifestations can have been reported in at least 43% of Fabry. And we'll talk about why that is, which is that phenotypic variation is really the rule. So here are some of the symptomatology that females will have. So you can see 43% will get burning and tingling in their hands and feet. 18% had left ventricular hypertrophy by echocardiogram. Now, it turns out that cardiac disease in females is a mixed bag because there's some females that have normal sized hearts. But when you do cardiac MRI, you actually see the scarring that the Fabry disease has left. So even if the echocardiogram is normal, it doesn't necessarily mean that the female does not have cardiac disease. You can see cardiac symptoms, 33.4%. We have females that have chest pain, that is from microvascular disease, that they'll get these chest pain. Renal failure, renal failure in this sense is progressed to dialysis. Many more females will have chronic kidney disease. GI symptoms are very prevalent. And interestingly enough, the NR on vertigo and tinnitus, I have a significant amount of patients, of females specifically. Nephrologists usually don't ask, do you have ringing in your ears and dizziness? But I have a significant portion of females that actually have vertigo, tinnitus, to the point that it actually is quality of life limiting. So this actually makes a big difference in how these patients feel. So renal involvement in females can be serious, right? And so once again, these are not carriers. So if you look at the male progression and you look at males with no proteinuria or limited proteinuria, that is urine protein to creatinine ratio less than 0.1, their eGFR slope is negative 1.6, right? So we all know that after the age of 40, for every year, it predicts that we will have a negative slope of 1. But in here, if you have no proteinuria, your slope is negative 1.6. Now, as that proteinuria progresses, just like many of our other proteinuric kidney diseases, you can see that the slope becomes more and more negative, whereas 0.1 to 1, it's a negative slope of negative 3.3, and greater than 1, it is negative 7. Now, that is a big deal. So males with a proteinuria greater than 1 gram per gram on PCR tend to have a very negative slope of -7. Now, females, if they were just carriers, you wouldn't see this. You would see a -1 slope, period. There would not be proteinuria, but in fact, there is. And if you look at these numbers, you'll see that if you have less than 0.1, you don't have that high of a slope. It's -0.6. But as you develop more and more proteinuria, guess what you do? You get more and more negative to where females that have greater than 1 gram of proteinuria will have a slope of -4.6. That is not 0. This is significant kidney dysfunction from Fabry disease. All right. So when does GL3 actually start to accumulate? And so here's one study where you have 2 females. So in the box, you will have 2 females that are 11 and 14 years of age. And even with that, you had segmental foot process effacement, and you had inclusions both in the podocytes as well as the distal tubular epithelial cells, et cetera. So these inclusions start from birth. Even in young females, you can see this. Now, these females, what we're finding is that the proteinuria is actually a late manifestation of the disease because the inclusions start, then you get segmental foot process effacement, then you get proteinuria. So by the time a Fabry patient has proteinuria, you can rest assured you're going to find something on the biopsy. All right, so females experience silenced cardiac symptoms. So they took 104 patients with Fabry cardiomyopathy, and the left ventricular mass was examined by cardiac MRI, right? And so historically, and this is one of the fights I have with insurance companies, for example, which is that they all want an echocardiogram prior to cardiac MRI. Now, it turns out in males, they are 100% correct, which is that in males, the heart gets big, and then you start seeing scarring via cardiac MRI in the left ventricular posterior wall. But females are different, which is that females can have a normal echo, and then you do a cardiac MRI, and you see disease. So most Fabry experts would suggest that in females, really the test of choice is a cardiac MRI if you can possibly get those. So very important to note that if you're a female, you do a baseline evaluation, you have a normal echocardiogram. Don't rest assured that your heart is not affected, because it may be. All right, so even oligosymptomatic. So what about patients who come in and you say, well, my dad got diagnosed, right? They tested me and I have the disease. And you start going through your symptom inventory and you say, you don't have that many symptoms. But even oligosymptomatic or asymptomatic females may have significant disease. And so one of the disadvantages of being a female, specifically with kidney disease, is just how we measure kidney function. So I just plug these numbers into an Excel spreadsheet for a 30-year-old female. And what you'll see is I have put in the creatinine values that are considered normal, right? So, most of our creatinine ranges go up to a range of 1.2. So, anywhere from 0.6 to 1.2 is considered normal, right? The MDRD equation actually tops out at 60. So if you had, UAB, for instance, had an electronic medical record that used the MDRD, and anything above 60, it would just say greater than 60, to which not nephrologists, but most primary care docs would say normal. It's normal kidney function because it's greater than 60. But if you plug those numbers in to the CKD-EPI equation, which has been modified yet again, this is what you would find, which is that, so at a creatinine of 0.6, this 30-year-old female, the MDRD equation would have 60, but their EGFR is 124. 0.7, it'd be 119 on EGFR, but the MDRD says greater than 60. 0.8, 102, 0.9, 88, 178, 1.1, 69, and then 1.2, 62. You've lost 60 cc's per minute of EGFR, yet your creatinine still says normal, right? So unfortunately, because most of these patients don't just start in nephrology, they start in primary care, but because we don't have a big red H that, hey, this is going up and it's still normal because the MDRD says it's still normal, most females are at a disadvantage and will get diagnosed with kidney disease at a later stage than men, right? Because men, the average creatinine in a male is actually higher, so they will reach that H level or greater than 1.2 at a lower stage than a typical female. Now, so point in case, a normal creatinine does not necessarily mean normal kidneys. And so this is a study that we did. This was, we presented this in Germany this year. And what you'll see on the left-hand side, this is 13 females with normal creatinines, meaning that their creatinine values were within the normal range. Now, their CKD epi equation actually ranged from 79 to 130. Actually, one of these 1.2 had 56. Normal creatinine, but the CKD epi equation said 56. So big ranges in the CKD epi eGFR. But even with those normal creatinines, look what we found on biopsy. So every single one of them had podocyte inclusions. All of their FOGO scores, so FOGO, Agnes FOGO is a phenomenal renal pathologist that had a scoring system for Fabry disease. And you can see the FOGO score for the podocytes was 2 to 3 in all of these. And look at this, despite the fact that these patients had relatively normal creatinines, there was in 5 of them, 50 to 75% segmental foot process effacement. So that 50% of these cells had completely effaced their foot processes. Now, interestingly enough, you can see their protein to creatinine ratio. You'd say, well, in those females, they must have had significant proteinuria, but that is not the case. So if you look at, for instance, number 12, right? So number 12 had 75% foot process effacement and almost nothing based on her protein to creatinine ratio, which should let us know that really proteinuria is a late stage of the disease. It is, so first you get GL3 inclusions, then you get effacement, then you get proteinuria in Fabry disease. All right, so females, so this is another biopsy study just correlating what we have shown in ours. And of these 12 females who had kidney biopsies with relatively normal protein to creatinine ratios, only 2 of them did not have inclusions. So once again, females are not carriers. Now, why is that? Why would you have such big variation? So some females, 4% will reach end-stage renal disease. There's a moderate group of females that will have chronic kidney disease, cardiac involvement, but may not reach end-stage renal disease. And then there is a group of females that is relatively preserved. So why is that? Turns out there's been 4 studies that have looked at phenotypic variation and lionization of the X chromosome. So historically, what we thought was that the X chromosome got inactivated. So we knew that one of the X chromosomes got inactivated. We assumed that it was random, and by random, that would be 50-50, right? So you get every female would have a 50-50 split, right, of which X was inactivated. So if you had a cell that inactivated the mutated protein, the mutated X, that cell would be normal, right? Because only the normal X would be active. If you have a cell that inactivated the normal, then all you had was the X with the mutated protein, so that cell would have Fabry disease. And it turns out when we biopsy female kidney, you will have a normal cell right next to a cell chocker block full of inclusions. So that is how that works. But what if it wasn't 50-50, right? What if 80% of your cells decided to inactivate the mutated X? Well, that patient will have 80% of the cells in their body with no Fabry disease, and they will look relatively normal. On the other hand, if you inactivate 80% of the normal, those females will look very, very severe, right? So in this study, what you'll see is this is what they did. There's a way to quantify the skewing of the X inactivation. So in line 1, so in the left-hand side, the dotted line is skewed toward the normal, meaning that 80% of their cells inactivated the mutated protein. And those patients had a relatively normal eGFR and a much more gradual slope in decline in eGFR. The middle line is 50-50, right? And you can see that's right in the middle, which is what you'd expect. And then finally, number 3 on the left-hand side is severe. So they are skewed towards the mutated protein. Now, the reverse is true about the left ventricular mass index. So if you skew number 3, right? So if you skew towards the mutated protein, you should have a bigger heart. And that's exactly what happened, right? If you skew towards mutated, where there's more mutated cells than normal, you will have a bigger heart. The middle is 50-50, and then the smallest heart is, which is what you want. You want your heart to be relatively small, not big. So that's where you get skewed towards normal. So skewing does explain the phenotypic variation, right? So if phenotypic variation is the rule in females, how do I approach them, right? I mean, how do you approach the management of a female? Well, the first thing is I want to digress just a little bit, which is, why do genetics? So why do we do genetics in kidney disease? The first thing, you got to diagnose the patient with Fabry disease. So let's take one step back. In this, it's how do you approach a female with Fabry disease? Well, the first thing, you're not going to know they have Fabry disease until you diagnose them, which means you got to test, right? So you need to test because there are, Fabry disease does not just affect the kidney. It affects heart, brain, GI tract, acroparesthesias, nerve. This affects quality of life, and it is not just a kidney disease. In nephrology, we need to do genetic testing because we need prognostic information for transplantation, and we need to do family screenings because those family members may need to donate to the patient who is end-stage renal disease. Like we just can't abdicate responsibility any longer for genetics. We need to identify family members. We need to definitely diagnose people that, diseases that there are treatments for, right? So who do I test for Fabry disease, right? So this comes from KDIGO. So in April of 2022, KDIGO actually put forth guidelines on who to do genetic testings on in kidney disease. So I test patients for genetic kidney disease, including Fabry disease, if they have a first-degree relative with kidney disease or ESRD, right? If they have onset of kidney disease before the age of 25, your yield is going to be very high that there's something genetic in the 10 to 30% range. Family history of Fabry disease absolutely needs to be tested. And other populations, this is not from KDIGO, this is me. I call them the chronic kidney disease plus syndromes, right? So CKD plus neuropathy without diabetes, right? If you have an explanation, you don't have to test. But if the patient has chronic kidney disease and neuropathy, what if those two were linked? CKD plus left ventricular hypertrophy. For neuropathy, I mean, some of your differential diagnosis, Fabry disease would be there, but so would amyloid, right? CKD plus left ventricular hypertrophy without hypertension. Most of us are going to go directly to this is hypertensive kidney disease, but what you're going to do is you're going to look at the blood pressure and it's going to be normal. And you say, well, why does this patient have hypertrophy plus kidney disease if their blood pressure is normal or very easily controlled? Irritable bowel syndrome, if this is one of the common ones, CKD plus irritable bowel syndrome, what if those are connected, like Fabry disease? Or CKD plus a chronic pain syndrome or fibromyalgia also should say, hey, wait a minute, these are things that we need to potentially link, right? So how do you test? How do you diagnose the female with Fabry disease? Well, the first thing you could do, you got to, the hardest way, and I spent 8 years trying to teach people about this, is you got to think about Fabry disease, right? So you have to say, oh, well, I think this patient has Fabry disease, so I'm going to send the Fabry gene and I'm going to send alpha galactosase enzyme activity. Now, if you send alpha galactosase enzyme activity in 30% of your females, it's going to be normal. So if it's normal, it doesn't help you. If it's abnormal, it may help you, but know that there's some pitfalls in testing. And I've recently had 2 false positive where the enzyme was normal, but on repeat, or the enzyme was low, but on repeat it was normal. So the enzyme activity level has some pitfalls. The other thing you have to think about Fabry disease, and the reality is that medicine is becoming increasingly complex. There's over 20,000 genes. Each one of those has mutations. Even in the Fabry disease, there's over 900 mutations. So it becomes very, very complex to think about one rare disease when there's so many out there that this could be, right? So option 2 is what I think most of us are actually going to gravitate to, which is that you don't think about Fabry disease. All you have to do is follow the KDIGO guidelines and say, could this be genetic? If it is genetic, send panel. If panel's positive, act on the panel. That is much easier for us to operationalize because historically, if I sent one gene and it was not positive, Well, that didn't mean the patient didn't have genetic kidney disease. It just meant I selected the wrong gene, right? So we've started to make this easy on ourselves. Cardiology did it much earlier than we did with gene panels, but there are companies now that are doing gene panels, which is making this a lot easier. If the Fabry comes back positive, that's when you need to say, what do I need to do with this result? And then the final thing, which makes it a little bit easier for kidney docs, is that if you identify the severe patient who has proteinuria, and what do we do with proteinuric kidney disease that we don't understand? We do a kidney biopsy. And when we get a kidney biopsy, you will see zebra bodies and whorls, and you'll say, well, what is the differential diagnosis for zebra bodies and whorls in a kidney biopsy? And there is a differential. Fabry disease is one of them. It is one of the most common causes. But the other ones that can cause this are drugs like hydroxychloroquine, chloroquine, and amiodarone also cause sphingolipid accumulation and can look like zebra bodies. So you're not done. Then you have to confirm it with genetic testing. All right. So let's just talk about, so now you diagnosed it, right? So that's how you diagnose. So let's talk about some of the approaches to the severe patient, the patient who is oligosymptomatic, and then the patient who just wants to watch or completely asymptomatic, right? Because females have a varying degree of involvement. So all of these females are not these are not real cases. These are representative cases, we'd say, but not based on real people. So you have a female who presents with fibromyalgia, fatigue, irritable bowel syndrome, and mild lower extremity edema, right? So a lot of docs, when we see fibromyalgia, fatigue, somatoform disorder, all of a sudden in our head, we say, oh man, this is a patient that's going to complain. When I see that, I look at that and I say, this is a patient that we cannot diagnose because we've thrown a bunch of words at disease symptoms without saying why a patient is actually experiencing them. And that's a problem. So I see opportunity there. So the EKG showed left ventricular hypertrophy. Her echo confirmed hypertrophic cardiomyopathy. Her lab showed a creatinine of 1.2, which is very abnormal for a female, and a proteinuria of 400 milligrams. And I already told you that 400 milligrams is a late manifestation. Proteinuria is late for Fabry disease. Father died of age of 42 of unknown causes. So always look for the family member who died really before the age of 50. I think that's a red flag. So normal, her physical exam is normal other than trace lower extremity edema. Note that I did not say this patient had angiokeratomas because females, a lot of times they will not have angiokeratomas yet can still have severe disease. And once again, you see the echo with LVH. So what do you do as a nephrologist with a person who has kidney disease, mild proteinuria, not greater than a gram, right? Greater than a gram, most of us would biopsy. This is less than 500 milligrams and they have LVH. Right? Well, some of us would just stop there, right? And we say, all right, well, we're going to start on ACE and RAS blockade and we'll follow up in 6 months. Now, in this patient, you just missed the boat. You missed the boat, right? Because you start on ACE inhibition, which is going to improve the proteinuria. But what about the pain? What about the fibromyalgia? What about the LVH? That's going to progress, right? What about the risk factor for stroke? So these patients, we usually treat their lipids a little bit differently. So, basically, yes, you could start RAS blockade, but you have missed the disease process. And that is what we want to avoid. You have to diagnose this. So outcome 2, right? You have somebody that said, look, this patient has fibromyalgia, they have irritable bowel syndrome, they have LVH, but the blood pressure is normal. They have proteinuria and they're young at 40. I'm 42, so 40, I'm going to say 40 still young. So we're going to do genetic testing or get a kidney biopsy, right? So in this case, so what do I do if the results come back positive, right? So I give talks about genetic testing and how to interpret them. And one of the scariest things that I get asked by nephrologists is what happens if the test results are positive? What am I going to do, right? So I'm not going to send the test because I am worried of what will happen if they're positive. And we got to get over that, right? So you send a gene panel, it reveals a pathogenic variant in the GLA. So in this case, so most testing will come back with a variety of results. Pathogenic, right? In this case, it's a female, so it'll say heterozygous pathogenic. That is not a carrier, right? The rest of these will be variants, right? So there could be variant of unknown significance is your next category, which you have to put the significance on, right? So sometimes when you get a variant of unknown significance, we need to say, well, this patient has proteinuria. They got a variant. Maybe I need to do a kidney biopsy to say that this variant is actually pathogenic. And finally, there are benign polymorphisms, some of these being D313Y. I won't mention A143T, which is debatable, but there are benign polymorphisms. So those are your three categories: pathogenic, variant of unknown significance, and benign, right? So if it is a variant that's pathogenic, well, now we have next steps, which is we got to determine what are we going to do about it. We already talked about variants of unknown significance. Is it a late onset cardiac? So usually what I do when there is a variant is I go to the database and look up that specific gene and say, what does this gene do to other people? If you don't want to do that or don't have time, the next thing to do is refer to someone who knows specifically about Fabry disease. And ultimately, as we learn more and more about rare diseases, it's going to be too complex. Doctors have to know about hundreds of thousands of diseases, and eventually you can't know everything about every disease. So if you don't, at least try and co-manage the patient with somebody who really, that is what they dedicate to. All right. So that's consulting a level of expertise, right? Or a center of excellence. So what do I do if the results come back positive? Well, you find a center of excellence. You do a baseline evaluation. That's really important in all of these patients, right? Once you know that this is a multisystemic disease, you have to do a baseline evaluation. That is a survey of all of the organs that are involved and what is actually happening. So for cardiac, you need a troponin for a marker of hypertrophic cardiomyopathy, cardiac MRI versus echo, and EKG. Our patients get Holter monitors every 2 to 3 years. For kidney, we know how to do that, right? We do creatinine and urine protein to creatinine ratio and potentially biopsies to characterize the diseases. Biopsies are incredibly important in females and variants of unknown significance. So brain, you do an MRI because this disease can cause white matter disease and you want to see what the extent is. We have had patients misdiagnosed with multiple sclerosis that ended up having Fabry disease because of the involvement of the white matter. You need to check for neuropathy, GI. A lot of our patients will say, no, I don't have GI problems. And then you ask, how many times a week do you have diarrhea? And they're like, 4 to 5 times. That's normal for them because they've had it from birth. So you really have to get into, are they having GI complaints associated with their Fabry disease? And then finally, we do Lyso GL3 and GL3, which are markers specific to Fabry disease. So in this case, this patient is symptomatic. You have a baseline evaluation. She has elevated biomarkers. Lyso GL3 and GL3 are elevated. So she has an indication to start Fabry-specific therapy. And right now, importantly, it's not good enough to treat her alone or to diagnose her alone. Because for every person we diagnose in a family, there are 5 affected family members. We got to find them. There's a possibility that they're doing even worse, right? And that we can prevent a stroke or a severe cardiac outcome by identifying them. So we are never done when we diagnose one member with genetic disease, and you need to get the rest of them screened. All right. So how are we going to treat? So a lot of people will think if Fabry, then Fabry-specific therapy, right? But it's so much more than that, right? Which is once again why you may want to consult a center of excellence to say, what are all the things we can do? So there are FDA-approved therapies now for Fabry disease, but there are adjunctive therapies. In my opinion, the adjunctive part of this is just as important as the Fabry-specific. So for kidney disease, what do we do for proteinuric kidney disease? Well, if they're proteinuric, we use ACE inhibitors and ARBs. If they are uncontrolled on max dose ACE inhibitor or ARB and their proteinuria is still greater than 500, we add SGLT2 inhibitors just like we would for other proteinuric kidney diseases. For the nervous system, for their risk of stroke, we treat their lipids to that of a patient who has a risk factor for stroke. So I like my Fabry patients to have lipid or an LDL less than 100. When indicated, we use antiplatelet agents to try and prevent stroke. There's also a high risk of atrial fibrillation in this population, and management of that is important. So GI, there is now a study with oral alpha-galactosidase. You may know it as Beano, right? So Beano, that medicine that we got for gas, actually is alpha-galactosidase, which these patients are missing. About 3 years ago, there were studies by Malta Lenders, which showed that oral alpha-galactosidase, or Beano, doesn't treat the disease, but it does help the abdominal pain associated with the disease. Cardiac, so our patients will get pacemakers and AICDs, and we do EKGs to predict when they need those. We usually do not put pacemakers alone in these patients because of the risk of malignant ventricular arrhythmia, so we start with AICDs. So it does change your cardiac management. You want to avoid beta blockers because the risk of bradycardia in these patients. Nutrition, we check vitamin D and B12 because there's a high risk of vitamin D and B12 deficiency, and then hearing. These patients need hearing aids sometimes and anti-vertigo medicines. All of these are really important. So let's talk about case 2, right? So you have, this is an alternative history. You got a 40-year-old, same lady, 40-year-old. Her physical exam is normal. She has a normal echo. Her creatinine is 0.8, not 1.2, so much better on the creatinine side. And her proteinuria is only 200 milligrams per gram, right? So you send the gene panel and it reveals a variant in the GLA gene. So it's a variant of unknown significance. So now you have somebody who has a relatively normal exam, normal creatinine, but they have a GLA, but it's a variant of unknown significance. Now, what you need to take from that does not mean it is benign. It just means we don't know, right? So how are we going to put something with that? How are we going to say, well, we know? Well, it turns out that Lyso GL3, you can do Lyso GL3 and GL3. These are biomarkers that are available now through LabCorp. So these are orderable tests. And if they are elevated, you can say this may be something that we need to do something about. So if you see here in females, right, in females, the average Lyso GL3 level in Fabry patient is around 5. But all of these black cases, right, all of these black little dots are patients with Fabry disease. And you can see some patients, there are some females with almost normal Lyso GL3, despite the fact they have Fabry disease. So Lyso is, it's great, but there are some females this is not going to help you out, right? Now, if you look at males, look at the difference in the male Lyso. The male Lyso is a factor of 10 greater than that of females. So once again, it's not, this is not a slam dunk in the female population, right? So you do a baseline evaluation on this patient. She's relatively asymptomatic, but she has this variant. Baseline evaluation is pretty normal. Lyso GL3 is 2, so that is elevated, which means that she may have something, but is that enough to say I need to do Fabry-specific therapy? GL3 is within normal limits. Kidney biopsy actually performed, and you show 50% foot process effacement. Now, most nephrologists would say, look, if you have 50% foot process effacement, that is histologic evidence that something is going on. So after the kidney biopsy, you say, wait, this patient really does have something going on. You do a cardiac MRI, not an echo. Cardiac MRI then shows late gadolinium enhancement. Now you have cardiac and kidney involvement, and you have histology. That is far more powerful than any biomarker that we have. So we have now established that this variant of unknown significance does in fact cause disease. And that's what our study showed, which is that just because this patient had normal creatinine, normal proteinuria, or relatively normal, that does not mean that the patient is not affected. You can find that on kidney biopsy. So your genetic colleagues, please, your genetic colleagues, I hear this all the time at national meetings, beg nephrologists for kidney biopsies in Fabry patients that have normal creatinine and normal proteinuria. Please, if Fabry is in the differential and there is genetic evidence that they have it, indulge them, because you get a lot of information about that they need. So finally, we have case 3. This patient is completely asymptomatic. Lyso GL3 is essentially normal at 1. And the patient said, look, I don't want therapy, right? I'm fine. I don't need anything, right? So what do? Do you just say, well, have a nice life? Well, the answer is no. You can't say have a nice life, because they may be fine then, but females need to be followed, right? Even asymptomatic females. So by and large, we'll follow our asymptomatic females about once every 2 to 3 years to make sure something doesn't develop that then needs us to rethink things. Because like I said, females actually will get disease, but by and large, they'll get disease delayed about 10 to 20 years from that of male. So we do follow our females, even if they are asymptomatic. So the key takeaways is this, which is that females are not just carriers of Fabry disease, they have real disease. Female presentation can be variable due to the nature of X-linked inheritance. So phenotypic variation is the rule. They are not carriers. They have disease, but the disease can be varied to severe, to not severe, and it is on us to actually determine that. We don't have a clinically available assay to look at skewing, so we use the clinical tools we have at our disposal: cardiac MRI, echo, kidney biopsy, creatinine, et cetera. We use the standard stuff. So females need thorough monitoring and assessment to determine when treatment should be started. And then finally, most importantly, probably, because I think if there was, the biggest opportunity that we have is we are missing these patients left and right. So I just gave you the patients that we had a diagnosis. For every patient that we have a diagnosis, there's probably 5 to 8 out there that we did not diagnose, right? We have to start using genetic testing in our routine practice. And it's not just for Fabry disease, it's for Alport's, it's for steroid-resistant FSGS, it's for transplant, it is for everything. We have to start doing this. This is nephrology is ours, right? As nephrologists, that is our territory, and it is on us to actually determine how do we use genetics to better the health of our patients. Once you have a Fabry patient, that's when you start using the data that we just talked about with monitoring, biopsies, et cetera. But females are not carriers. So with that, I will take any questions.
Well, thank you very much, Dr. Wallace. Great presentation. You've gotten some positive feedback in the chat and the Q&A already too. And I certainly, speaking for myself, definitely learned a lot from that talk. In fact, just to kind of indulge myself, that last kind of point about genetic testing, I'm wondering, how do you see the role of like a genetic counselor in that process? If it's a daunting task, as you mentioned, for nephrologists to learn this, what role do you see for genetic counselors?
Yeah, no, really where there is overlap, which is that most of the time the first diagnosis will happen with a nephrologist, a cardiologist, an ophthalmologist, because they can see the worlds, dermatology. Where I see the genetics counselors coming in primarily in clinic is helping screen the family members, right? The other place that I see is the genetics counselor actually helping push the nephrologist to say, hey, we might need a kidney biopsy, we might need something. This is just a variant of unknown significance, and we need to start helping inform these variants. The other place that I really think genetics counselors will be huge in is that once, nephrologists are not trained in how to change the criteria for variants of unknown significance. So the more data that we have on variants of unknown significance, we have to get that data to the American College of Medical Genetics or the people doing the testing to say, change your database. When they change their database, they may find lots more patients out there that we misclassified, right? So I think more and more, we have to actually work together and hand with genetics and genetics counselors to say, look, we have histology. If I have histology in a variant, that's not a variant, right? That is pathogenic, and we need to classify it as such.
Great. All right, well, so I'll start with the audience questions we have here. So have you seen elevated levels of urea in blood of Fabry patients?
Oh, absolutely. Yeah. So basically, when I say elevated urea, so just the differential of elevated urea is I have kidney disease. Now, as the creatinine goes higher, your ability to excrete urea goes down, so your urea levels go up, right? Now, there are other reasons for it as well, which is increased protein intake, prednisone. So some of our patients get misdiagnosed with rheumatologic diseases, and they're on prednisone, which causes urea. So but I do not think an elevated urea on its own is going to help me in Fabry, right? That is not specific to Fabry. It is very, it is just a non-specific marker of either kidney disease or something else going on. But yes, we have seen elevated levels in Fabry, but just like anybody with kidney disease.
A follow-up from the same person that asked, and then can you have normal creatinine with elevated urea?
You can, but that's not specific to Fabry disease. So we always say there's 5 causes of it's azotemia without uremia, right? So an elevated urea without symptoms or without kidney failure. And that is increased protein intake, prednisone, medicines like minocyclines, they're the tetracyclines, blood in the gut. So sometimes people with GI bleeds, and then an increased protein diet like TPN, things like that can cause a very elevated urea with a normal creatinine. But in females, the question is that you can have a normal creatinine, but having a normal creatinine in a female, some levels go up to 1.3. Well, you could say that your creatinine is 1.3 milligrams per deciliter, which is normal, but in a female, your GFR, what that means for your kidney function means that your GFR is probably in the 50 range, right? So it depends. Can you have elevated BUN with a normal GFR? Yes, but is it really a normal GFR, or is it just a normal creatinine? That is the distinction.
Okay. Question, in women with podocyte abnormalities and normal protein excretion, did you measure albuminuria?
We did not in that case series. We usually just measure proteinuria, and most of them have when I say normal, most of them were either undetectable or to around 300 or 400. So once you have detectable proteinuria, and if I can even go back to that slide, hold up 1 minute. Let me go back to my case report because I can look at the numbers. 1 minute. It's going slow. Well, I'm going to show you exactly how much. The next one. There we go. All right. So if you see the UPCR, right? So in number 2 and number 3, where they had 60 and 40 milligrams, these may have been useful to check albuminuria, but we didn't because we have the kidney biopsy. And then the 0.08. Once you have detectable proteinuria, which I would think is anything greater than 0.15, then we don't check it. We don't check the albuminuria plus the proteinuria. We just go with the proteinuria. So in this case series, I did not check albuminuria, but you got to think, right? Which is that. So in this disease, right? In order to get proteinuria, you have to have something wrong with the filtration process, right? So what happens to that protein when it passes the filtration barrier is it goes to the proximal tubule. The proximal tubule has these megalin-cubulin complexes that actually absorb proteinuria, and they have a reabsorptive capacity of anywhere from 500 milligrams to 1 gram. So all of a sudden you say, well, man, by the time that hits the toilet, you have overwhelmed the proximal tubule's ability to reabsorb protein, which is why it's probably late, right? If you could test it at the proximal tubule, then you might catch it even earlier, right? But because in order for it to make it to the toilet, you've overwhelmed the proximal tubule. That's probably why it's more late than we actually think.
Great. If the patient is a female with a confirmed GLA pathogenic variant, but without symptoms, without lab signs of compromise, can she start enzyme replacement therapy to prevent or delay development of symptoms?
The answer is, so I guess, all right, so you have a pathogenic variant, right? And so pathogenic in this case usually means that there's some data that this is going to cause disease. I would argue that most females with pathogenic variants will have something. Now, realistically, there are requirements that you have to meet for insurance coverage, right? For any of these therapies, right? Specifically, do they have an elevated Lyso GL3? So in general, I think you'd be hard pressed, even with the pathogenic variant, to have a normal Lyso GL3 and then that get approved. I have gotten it approved, but only if I showed histologic evidence of damage. So if you have an elevated Lyso GL3, that may be enough. But if it's not super high or if it's close to the normal, you may have to go one step further and do the kidney biopsy. And recently, well, not really, about 5 years ago, I had about 4 of my females specifically. Females are the ones most at risk of actually losing coverage of their Fabry-specific therapy. And I had 4 females that actually lost their coverage, and I was able to salvage it because in all of them, I had a kidney biopsy. So there's a much more practical reason why some females with asymptomatic and normal baseline evaluations might need kidney biopsies, because if you have those, then you have to show somebody that this therapy is going to be treating something. And I don't think well, at least in my experience and in my state, a genetic mutation without other markers of disease would not be enough.
Great. Right. If there's time for one more question, you talked about, asking questions and kind of putting that whole picture of the patient's symptoms together. And it's something we see with all kinds of rare diseases, including Fabry. What do you do to kind of bring that out of a patient when you're seeing them? Because, they're at the kidney doctor. They may not be associating some of the other things that they're thinking about with you. So how do you do that? And what do you recommend for like PCPs when they're doing it?
Well, I'm spoiled, right? Because my clinic is called the Fabry and Rare Kidney Clinic. And I actually have more time, right? So in my clinic, I got about 30 minutes to an hour with each patient. So I'm very spoiled. But I think the big thing is that as far as eliciting other things, right? The first thing that we're going to do, just in a usual scan of what we do, is a family history, right? So we're going to do a review of systems, and you're going to do a family history. And what should start going off is LVH, neuropathy. The neuropathy is going to be big. Do you have tingling in your hands and feet, right? Family history. But when I'm talking about family history, what do we usually do? We say, do you have anybody with kidney disease, right? I would press people to expand that just a little bit, right? And say, any first degree relatives with kidney disease, any males under the age of 50 with a stroke, right? And any sudden cardiac deaths that were unexplained, right? So did you have family members that died at young ages that you just didn't know why, right? Those should all trigger, hey, maybe I should think of something more, right? Once they have a gram of proteinuria, you saw those slopes, right? So in these patients, most of the time, by the time they get referred to nephrology, they get referred to nephrology because they have kidney disease, right? And when they have kidney disease, a lot of times we do kidney biopsies when they get proteinuria. So the key is when you get protein and you get those whorls, you're not done. You got a family to go after, right? Because now there are things that can be done to try and prevent sudden death, right? And that's the problem. Unfortunately, I have too many daughters who learned about their Fabry disease because their 40-year-old dad died, right? So we got to prevent that. And you're not going to do it by just sticking with the patient in front of you. You have to say, look, you got to talk to your family members. They have to get screened. And if you're uncomfortable as a nephrologist doing it, there are people that do that, right? There are Fabry specialists, there are genetics, and all you have to do is say, look, I have one patient with Fabry disease. What are we going to do?
Great. Well, I think that's all the time we have for questions today. I want to thank and give a huge thanks to Sanofi again for their support of this program. Thank you to Women in Nephrology, WIN, for their partnership, and of course, Dr. Wallace for the great presentation. I'd also like to thank the audience for tuning in, asking such great questions. Please remember to complete the short survey that you will see once we conclude. And I'd also like to remind you to visit our website, www.kidneyfund.org, for more great Fabry resources. Thanks, everyone, and have a great afternoon.
Thank you.